Not, I need a motion on accepting the agenda as written.
So moved.
Moved by Clint,
Second. Cool.
Cole, seconded. Any further discussion on the agenda? All those in favor?
Aye.
Any opposed? We have some recognition. See Nolan's here. Is Cynthia Larson here?
She's not able to make it. So just kind of a reminder of what our star recognition is we anybody can get nominated by another employee for going above and beyond, helping teammates, helping patients, and then those nominations go to our employee recognition committee, and they vote on one winner, two winners, however it might work. So this month we have two winners or recipients, and both of these moments that I shared just show the true strength of our Star Valley Health family. So many of our employees not only care for our community members or people that they have never met before, but then outside of their work day, they look to go help their coworkers. So I'd like to recognize Nolan Heiner. You want to come up here?
Go ahead, you're gonna.
Yep, so Nolan has worked for Star Valley Health for 21 years as the supply chain and material management director. Nolan was nominated for going above and beyond for his coworker in a time of need. So this is what they shared with the committee. Nolan took his time on Sunday to pick up my kids from Grover and drive them to Ermac to visit their mom, who was recently life-flighted from Star Valley Health to Ermac. He made sure that all got dinner and waited around for a few hours so that it wasn't just a hi and bye, and then took them back home to their grandparents. The sacrifice of his time to prioritize my family and trying to help with recovery is going above and beyond for coworkers.
It's something you just regularly do, I know.
Shake hands again, please.
Uh-oh, you didn't get the moment?
No, I didn't. I missed it. Perfect. Thanks.
Thanks, Nolan. Appreciate all you do.
So I'd also like to recognize Cindy Larson. She unfortunately wasn't able to make it, but Cindy has worked as a nurse at Star Valley Health for just over a year. Cindy was nominated again for going above and beyond for her coworker. So Sydney works side by side with my wife, and hearing about her incident that left her in Ermac, she took the time to put together to get a better, quickly package that included all of her favorite belongings, along with flowers, and to try and bring as much cheer and happiness as possible to the situation and put a smile on her face. While she did it as friendship, it was the personal time, concern, and additional care for a coworker, and instilling that friendship between coworkers is extremely important in providing the best patient care. So congratulations to Cindy.
We appreciate all our employees, especially those that go above and beyond. It's nice to hear about these things. Let's see, Chief of Staff report.
Let me know.
Yeah, it's happening.
Oh, just let me know that's.
Everybody's scared of it.
Okay, thanks.
You're on unless you need to take a call. Doc?
What are we doing? Sorry.
Chief of staff,
Oh, I can do that.
you look like the guy that could.
What's that?
You look like the guy that could do it.
Oh,
That's an introduction.
that's an introduction.
Drum roll.
Yeah,
Cloud
seriously, right? Okay. Thank you. Sorry, a little distracted. So Nolan's not here, he's left, but from a medical staff standpoint, super kudos to Nolan. You need to know he's amazing to work with. Other places, Nolan's just a can-do kind of guy, and he is incredibly pleasant to work with. And you know, so I hear these things that they're doing, and you know, there was somebody, one of the staff sent me an email, and it was entitled Event Report this week. And I don't get those. I don't get event reports. And so I'm like, what in the world is this all about? Well, she wanted to recognize a certain physician that came in, rearranged the schedule, came in on and sat with her mother before a procedure because her mom trusted this physician and only felt comfortable if this physician would come and sit prior to a procedure, prior to an operation, you know. And so, yeah, the event report was positive. You know, we'd like to see more of those kinds of things. You know, I got a call 2 weeks ago from a patient of mine that's also a patient of another physician. And the physician was just leaving their house because the physician didn't have a ride to get to clinic, so he scheduled a home visit. I don't know who does that. I don't know an orthopedic surgeon that does home visits. It's interesting. In April of 1910, Theodore Roosevelt gave a talk that all of you know. It's called The Man in the Arena. You've all heard it. But it was part of a talk called Citizenship in the Republic. We don't have time for that. But a more worthy read I can't think of. Let me share a couple of things. You've all heard this, but it comes into play. So let me preface it by saying the medical staff at this point, medical staff ebbs and flows. We have highs and lows. We have new physicians starting that we're really excited about. Jordan Lee in anesthesia, Jared Tyler in anesthesia. We've had some new ER providers start. Dr. Medina is going to be my neighbor. She's bought a house in the neighborhood. And we've got Dr. Bettinelli starting in Evanston. These are all super good people. Super good people. But we've got some of our core that's struggling right now. I'm going to be very honest with you. They're struggling. And for the last couple of weeks, I can't get this out of my head. And as we struggle, all of us in this room struggle with public comment and perception and everything, this always comes to mind. And the Man in the Arena, it's been quoted so many times. LeBron James has it on his shoes every game that he plays. When Tom Brady had a documentary done about him, that was the name they gave it. It is not the critic who counts, not the man who points out how the strong man stumbles or where the doer of deeds could have done them better. The credit belongs to the man or woman who is actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs, who comes short again and again, who spends himself in a worthy cause, who at the best knows in the end the triumph of high achievement, and who at the worst, if he fails, at least fails while daring greatly, so that his place shall never be with those cold and timid souls who neither know victory nor defeat. I thought about what to even report on. And for the last 2 weeks, I can't get this out of my head as I struggle with physicians that are struggling and how can we help them, and you know, the public perception that it's just a piece of paper. And as we all in this room deal with criticism, you know, we're engaged in a worthy God. we're engaged in something that matters. And we are in the arena. And I guess what I wanted to share is I'm grateful I'm in the arena with the medical staff. And I'm grateful I'm in the arena with you all. And even though the vocal minority may be the ones, you know, barking at the wheels are gonna roll, and they keep rolling. And that's how I view the medical staff and Star Valley Health moving forward. And so know that the struggles that every one of us are maybe going through or feeling, or we know somebody that's that, you know what, they're in the arena. They're trying, it's a worthy cause. And it makes a difference and it matters. So everything that everyone in this room does is not unappreciated. It may feel like it, but it's not. So thank you.
Thank you.
Thanks, Doc. Anything in the consent agenda, financial results that anybody wants to discuss or ask questions about? The consent agenda. Okay.
I have some questions. No, sorry.
Oh, what would you like, Paul?
I just had a couple of questions on some of the disbursements.
Okay. That's bills, and so we'll hold those out of the consent agenda. Anything else? I need a motion to approve the consent agenda, except the bills against the district.
We need a motion to remove the disbursements.
Oh, that's what we need. Motion by Mindy to remove the disbursements from the consent agenda. Thank you.
I'll second that.
Seconded by Abby. Thank you. Any other discussion on the consent agenda? All those in favor?
Aye.
Any opposed? Why don't we take those questions now, Mindy? And if anybody else has any questions on those items,
I noticed Scott isn't here, so I guess.
see online.
No, he's
Pretty sick.
he's pretty sick.
We'll attempt to answer them.
I just had a couple of questions. Anthony Cameron, is that we have paid him quite a bit last month, like 3 different times, and one looked like a duplicate, and I just wondered what that was or what.
Yeah, page 1.
I have to, So it's $14,040 3 times in July,
There it is.
twice on the 7/31.
You can. Go ahead, Tom. Mr. Chief.
He's an emergency position?
So it's like.
This is,
So did we double
employee.
pay
I
him
don't-
though?
I don't know the details of the payment, I'm just letting you know.
Okay, that's who he is. Okay,
So
thank
is
you.
that a locum or a,
Kind of. We have a professional service agreement with individual physicians. It's part of the Mountain West, or the Mountain.
I thought it was kind of like.
Is it possible that we have a contract in place with him for his regular hours and then like ER physicians do like 48 hours and then he maybe takes on extra shifts we pay him for?
Yeah, I
It's
think,
hard to say.
I think what we could do, Mindy, is with your questions, let us research it and we can get back to you.
Okay, that's fine. I just noticed he was paid twice on the 31st, or, it's 3 times in a month. I just wondered. Anyway.
Okay.
what about Kelly Titzel?
Yeah, I wondered about that one too.
It's
I
the
had
same
that one
one.
too, yeah.
He had 3 payments identical,
Mhm.
but they were
Trevor has that.
different. Well, the last 2 were the same day.
Mhm.
That's gonna be ongoing because he's a CRNA that's employed with us, but has a contract.
He's not, so he's technically not employed.
He's not an employee.
He receives a 1099, so he's gonna show up on this list.
Okay. So he doesn't get benefits from the hospital?
Correct.
He's just, he's a 1099.
But he's a permanent PSA.
I know we paid I Bailey, and I just wondered, was that for last year's audit, or is that for this year's? The one we just sent to him, I just wondered.
I don't know if that particular bill is for last year's or this year's.
Okay, we just, yeah, pulled these out.
Okay.
And then it looks like Gibbs, 22,000, I just wondered what that was for. Yeah, well, we paid Earl Gibbs, then we paid Eden Aerospace, and then we've also paid Gibbs 22,000 for something.
Mike, do we know what that is for?
Let me research that, Mindy, and I'll get an answer for you before the end of the meeting.
Okay, thank you, okay. I think that was all, thank you, I think that's all the questions I had.
Mr.
Chairman?
Mr. Chairman, so, Dr. Cameron is on a professional services agreement as well.
Okay,
Thank you.
both Anthony Cameron and Kevin Tietzel.
Yep.
Teitzel. Okay. Other questions? Okay, let's, need a motion to approve the bills against the district.
So
Motion by Cole. As for lack of
a second.
Clint seconds. Any other discussion? All in favor? Any opposed?
Mr. Chairman, make one suggestion, just for everybody when it comes to disbursements. Feel free to email us your questions before the board meeting. That way we can, do the research beforehand. And certainly we can have a discussion in public about it if you want to raise those questions, but it'll allow us to, make sure that
We just expect Scott to be here because it's got it on the top of his head.
well, even Scott sometimes might not understand every single transaction that's flowing through, so.
Yep, that's fine. Okay, unfinished business, we're down to a report from our finance and construction subcommittee.
You've got to approve the consent agenda.
What's that?
You've got to go back and approve the consent agenda.
Because we pulled it out.
Right.
Bring it back in.
You didn't approve the other part.
Oh, we moved to pull it out, but we haven't approved the consent agenda. Okay.
Sorry.
Need a motion to approve the consent agenda?
So moved.
Abby? Seconded by Jeff. Any discussion? All those in favor?
Aye.
Any opposed? Okay. Thanks. All right, now we, and I believe this is gonna be Jeff
Yes,
reporting on the finance and construction subcommittee.
thank you, Mr. Chairman. The Finance Construction Subcommittee meeting was held on Monday, the 25th of August of 25. In this meeting, management presented the financial results and statements of position for the 1 month ending July 2025. And some of the more significant items of note include the patient's accounts receivable and the cash trapped in AR declined through the course of July 25 due to the hospital's improved efforts at collecting on these accounts. The days cash on hand decreased in July, but is outperforming management's expectations at this stage in their plan for returning to target. Management represented to the committee that the days cash on hand is already improving with expectations of reaching 59 days by the end of August. Short-term debt saw a significant decrease in the month of July as a consequence of improved collections, and management expects that this balance will be paid off in its entirety by the end of September again, which is ahead of plan. Outpatient revenues outperformed plan due to measurable increase in the number of deliveries, observations, ED visits, physician clinic visits, and though management could not identify any notable reasons for these increases that contributed to the increase in the revenues. Bad debt and charity deductions increased for the month of July. Management represented to the committee that this was the consequence of an increase in balances deemed uncollectible resulting from the improved collection process, and because discounts offered as a result of paying cash up front for services captured in this line item. Management also identified that there was an increase in professional and purchased services over plan, but these but that these expenses will slow down in subsequent periods as these services are shifted to new hires and the related expenses are captured as salaries and wages. The committee discussed the overall cash position of the hospital, management's performance against their plan for recovery toward achieving its debts covenants, and management's general satisfaction with July's performance against plan. Management provided additional visibility to the subcommittee in regards to upcoming capital and maintenance projects. Management reported that the Diamondville rental opportunity is expected to be operational by the end of September, and that the costs associated with turning up this facility and operating it are to appear in the statement of operations. It's also reported that the Alpine Temporary Health Board is through HOA and city permitting, with site prep expected to be completed by mid-September. Management also reported that this temporary health board will be expensed on the statement of operations, though offset by $7,300 in donations received. Finally, the Alpine Clinic X-ray remodel project is expected to have its steel support structure in place by mid-September and fully operational through mid-October. Costs associated with this remodel are included in the capital budget for the current fiscal year. And then we've already addressed the complete list of disbursements made. So this concludes my report.
Any questions? Mindy?
So what is our day's cash on hand as of today? Do we have
I believe it's 44.
they predicted 59 by the end of August, right?
No, I don't think we
Oh, I
predicted.
thought that's what the report.
That is what my report said, so my notes are maybe incorrect
Predicted 59?
Yeah,
by the end of the month.
yeah.
So,
No,
No, that's days and accounts receivable.
days and accounts receivable.
Oh,
Yeah.
okay.
Yeah.
Sorry, 44 days cash. on
Yeah,
hand.
so we're at 62 days of accounts receivable right now,
Okay.
and we're pushing to get that under 60 by the end of this month.
Days cash on hand at 44. I have another question. When, are we looking to get in a better cash position before we put that money back in the employee's retirement that we held out for those?
No, we're still planning on,
When is that? Do we have a date that that's going to?
yeah, so the plan is to pay off the 11 point something million by the end of September. And then what we've told employees, we're gonna have that done by the end of December of this year. So we don't have a specific month that we've committed, but we still have it as a plan to get those funds back into the accounts.
Thank you. Okay.
Mr. Chairman, I said a follow-up for Dan, if that's okay. With that being said, we're accruing for that though, currently, right? We've been accruing to
Yes.
Well,
put that in.
so remember, we reinstituted, we're now contributing.
You're contributing?
All right, they are contributing. I know
Okay,
it's not
I
the,
guess
I meant the, when we missed. putting
Yeah,
that
Cole's
in.
asking,
But
are
when
we
we
gonna
missed,
see a
it was
huge
accrued
dip?
for.
And then those 3 months we accrued for.
Yes.
Yep.
Okay, that's what I wanted.
Yep.
Okay. One other thing, Jeff, I didn't know if you want to report on, I just caught a brief bit of this in the meeting. But the auxiliary is putting forth some money. Aren't
He
they, on
said
that?
yeah, that was
Okay.
the
So they have-
$7,300
Yeah, I missed that,
of
sorry.
charitable contribution for the helipad, yep,
The temporary one, right?
the temporary one. And thank you.
Yeah, sorry, no, I
Yeah,
didn't.
you
catch
said
that.
it. You didn't name who it was.
Yeah, I didn't name who it was, so thank you.
You left it as an anonymous donation, but now it is.
They're fine with you know.
Not-
Yeah.
They worked really hard to
I-
earn that money.
Yeah, I'd say, I think it's worth noting.
No, it's in their minutes, so it's public.
Yeah.
It was in the newspaper, so,
Okay.
yeah.
We put in the Friday flyer.
Mhm.
So.
It's
Other
also
questions?
in the 6 newspaper. It's not too anonymous.
You know,
I guess I just have one mic on Diamondville. The temporary we're putting down there. If all we're sending is our pain guy and our orthopedic, that facility's gonna be used, what, twice a week? Twice a month, excuse me? How often will that actually be occupied, I guess? We're spending how much a month to rent that?
Which question would you like me to answer first, Mr. Chairman?
Either one you want to, as long as we get to all of them.
It's our intention to start with Dr. Stuckey once a week his team, either he or his PA. One of his PAs will be down there once a week. Dr. McClure, I think he's gonna start with once a month. And then he will expand from there as needed. I know there's discussion about having other specialties go down there. For instance, if Dr. Gonzalez can fit it in his schedule, do cardiology down there. Others that would be willing to go down there, Dr. Hauser, since he's going to Bridge Valley, maybe he'd be interested in going to Cameron too. We've got to iron those details out, but I think there's an opportunity for additional specialties to go down there to use that clinic. And honestly, if I know where you're going with this, Mr. Chairman, and that is, do we have space to open an urgent care facility along with the specialties? And that's certainly under consideration right now as to how we could work that out as soon as we can to provide more service to that community down there.
Was that what you were asking?
Actually, that was my next point. So what are we paying a month? Wasn't it like $4,000 a month?
The lease on the building is, I think it's right at $3,100, $3,100, something like that.
Okay.
But of course, it's gonna cost us some money to get it put in place and get the utilities in and get the ramps up and concrete poured for sidewalk and that kind of thing. So we'll have some costs involved in that, but a lot of it can be, the utility extension costs can be used when we decide to put a permanent building in there. I hesitate to say how long we feel like this building that we're placing will be there. Maybe a few years, maybe longer. Depends on how busy we get and what the needs are down there. So.
No, yeah, my point was that it seems like we're gonna be spending $3,000 a month, $3,100, whatever it is. And we're there only part of the week, 1 or 2 days a week, 1 day a week, and once a month. Seems like a pretty empty building. And so I think we oughta use it as efficiently as we can if we're gonna spend that kind of money. We've talked about having possibly an urgent care down there or other local physicians, so. I don't know, I just wanted to make sure that we're thinking about that because I think that would be the better spending of the money, I guess, in my mind. And so, and I don't know what the political fallout of that is, but we're gonna be down there, so we might as well fill our building, is my thinking, so. That may not be the board's thinking, but that's Marlo's thinking, so. Other questions? Okay, quality, Abby?
Our meeting was held on August 19th at 11:30 in the Great River Room. Key points to discuss, Mark Larson, APRN, is working on a quality project to study diabetes. Trying to get an increased A1C testing done. There was some back and forth on what metrics should be gathered, what the end goal is. One barrier to the project looked like getting orders, standing orders. Dr. Kirk helped us see that maybe just a policy could be approved to create that for standing orders so they don't have to just exist in the system, and that should help move this along. Reading through the board packet, it seems like projects like this could be very beneficial, especially for those looking for, the grant for rural health. I think they're looking for metrics. This is something we have to provide anyway. He's kind of pulling a 3-month one, and our numbers look terrible there. And over the year, it looks a little bit better, but I think we found some common ground at like the 6-month mark is probably a positive metric to look at because that's what we report on. As per usual, all of the department indicators are showing excellent care. They're finding problems before they really ever exist. And they've been working on, maybe a few of you have heard when there's not rides for patients or if they're between two different facilities, that's creating some challenges, but they're working to use an Uber Health, that's going well, and then formalizing the process that the Uber Health isn't available, like what our next step would be as far as getting patients back to their homes.
What's Uber Health?
So I don't know if they offer a discounted rate, but if it's okay, like Sadie could manage that.
Yeah, it's basically just an account for the hospital to order Ubers for patients.
We have Ubers locally.
Yeah, there's somebody we're working with,
Really?
yeah.
There's a couple of them. We actually have their direct contact too, so if they're not showing that there's any Ubers in the valley, you can
They'll
contact
click on
them
their
directly.
system that they're available. It's a nice conversation, like as patients like, I don't have a ride, we offer the service, we'll coordinate it for them, but I do believe they pay for the Uber. And so when we tell them the rate that the Uber's gonna charge, like magically, somebody shows up to take care of them, but it's definitely a good backup if that's not available, so. I think that's positive. It allows, I think it's good. That's my report. Any questions? Anything I missed, Andy?
Do we have any questions or comments? Okay. Andrew, I wanted to go back to finance in the minutes. Up at the top, it says Scott was absent along with Carrie. Down at the bottom on item number 3, it says Scott Grammer updated the committee. And I was wondering how that
Finance
occurred.
committee minutes. I can
Finance
take that out.
committee minutes. Up above that, it says he was not able to attend, and then all of a sudden he's reporting. So you might just read through that.
Yeah, I'll fix it.
Seems like there was a couple of places down on item number 4. I think that's just a cut paste probably from the last meeting.
It was.
If you're like me and try to copy from the previous, I think it's easier. Anyway, if you just go through, I was just wanting to note that, so our
I'll get that fixed. Thanks for pointing it
consistency
out.
there. All right, we don't have a report from Ethics, Compliance, and Technology Foundation report. Sean is not, oh, you are here. Thanks for,
I think it was Jeff, right?
Jude, were you at the foundation meeting, Jeff or Sean?
I was not the last. Mr. Chair,
Well, that was the.
the foundation did not meet
That's right.
this month. They're meeting
Oh.
on July.
Yeah, and the minutes just include the previous one, because they're so
So
close.
there is a report.
Yeah. Skip.
And I believe Ethics, Compliance is next month?
Yes.
Is that correct?
September 11th, right?
Oh, that's a great date. All right. Auxiliary report,
That's me, Mr. Chair. Jeremy Price, this meeting was held August 5th, 2025, 1 o'clock in the Great River Room. Jeremy Price presented on recruitment, new providers, and these gals are wonderful. They use this meeting to make decisions on where the funds would be dispersed to the hospital. The physical therapy asked for a grant to get water bottle filling stations in the facilities in Thane and Afton, similar to the ones they're using in Alpine, and that was approved, which was very generous. And then they put money towards the temporary helipad in Alpine. They have another BMO night. That was well attended. They're very generous ladies. I don't want to like stir a lot of whatever, but I think it's very generous that they're donating towards the helipad, and it appears like it's a good process to check the temporary site out before we invest a lot more money into the other one, but just want to make sure it's on public record that these gals do a lot for this hospital, and they're looking for ways to serve the best possible. And it's my plea that the money that is awarded by them is viewed very, like it's a very special offering. It's a $1 bingo ticket and a cookie and a raffle ticket sale at the time. So I'm kind of passionate about these gals, and they're so generous that I just want to make sure that we are very grateful for what they do aside from the money they give and the time that they spend, which it's in the board to report the amount of hours that they spend in service, right, Andrea, or is that part of this?
Yeah,
It's
it was
in there.
like
If you guys review that,
2,500 hours, something like that.
and
last year.
honestly, I would bet that it's more than that. This is probably one of the hardest things for them to keep track of all of the good that they're doing in the community, but they matter. I know you think that too. I know everybody appreciates them, but I'm really grateful for what they do for our hospital. They're the heart, they're pieces of the heart of the hospital. That's my report.
And any questions on the fundraising or volunteer hours? There was a report in our board package. Andrew, I'm just gonna go back. The date I noticed was it's the minutes at the top of the minutes for the last meeting. I think it says June 25th. I
Oh,
think
okay,
it should
instead
be
of the
22
22nd.
July,
Into July.
just as a cleanup. Okay, moving on. CEO report.
So, let me just touch on some highlights in my report that I submitted to the board. First and foremost, I had individual meetings with the state of Wyoming, with Teton County and Teton County School District. I provided them insights into the negotiations, provided them our perspective and our point of view, and left them with that information to do with what they feel is appropriate. So wanted the board to know that that is the latest discussions about the whole Cigna contract. They appreciated knowing certain facts. One really didn't want to hear the story. They just, it was more of a business transaction, I guess, and so it was a pretty short call. The other two, it was a good back and forth, a lot of good questions, and then we'll see what happens going forward. Okay? Any questions about that?
Anything new with Cigna?
Nope.
Do we know how it's affecting us at all, or are we still getting patients with Cigna, but they're having to pay out of the network?
I don't think, coming up on 2 months since it terminated. I think we're monitoring it. There are some folks that are Cigna patients. They're still seeing their providers, obviously utilizing their out-of-network benefits. As far as the overall impact, might be still too soon to tell. Okay. Wanted to make sure that the board, looking down the road, what could potentially impact not only our hospital, but other hospitals in the state. And that is Mountain Co-op is leaving the market come January 1, 2026. Mountain Co-op is an insurance company based out of Utah that has provided insurance on the exchange. And so the exchange population is this gap of people that make too much to qualify for Medicaid, but they don't have insurance through an employer. And there's really 3 players on the Wyoming exchange that they are United Healthcare, Blue Cross Blue Shield of Wyoming, and Mountain Co-op. Right now, here's some of the facts. We anticipate Blue Cross Blue Shield of Wyoming and United Healthcare to increase their exchange prices between 20 to 30% before subsidies are applied. So before the premium tax credits, assuming Congress extends those and the current expiration on those are December of 2025. There are approximately 41,000 Wyoming residents currently using the exchange for health insurance coverage. And the organization needs to prepare for more uninsured patients seeking services from Star Valley Health, especially through the emergency room. County-specific numbers are unavailable. At least I don't have access to them. But if you extrapolate Lincoln County's population as a percentage of the state's population, 3.6%, roughly 1,500 people are enrolled in the exchange as a proportional estimate. And so all of this will happen at the turn of the year. And like many throughout the country, we're going to see the uninsured population start to rise, especially when the Medicaid cuts, if the Medicaid cuts become permanent at the end of 2026. So there is an option where, you know, this particular Congress has got all the goodies that they wanted to, gave, you know, the public a pathway to offset the increases in the tax cuts, and, you know, no tips on wages, or no tax on tips. They could, I think they're going to leave it to the future Congress in that midterm to decide what they're going to do from November until the end of January to decide how they're going to manage that Medicaid. I think that there's going to be a lot of unhappy people in a lot of states with, you know, what will happen to insurance coverage in the United States, and what that means to the overall commercial insurance group, as well as hospitals and physicians, and providing for care that's uncompensated. So could potentially be a big step backwards as it impacts healthcare providers. But the first thing that is really going to hit us is in a few months, and we're already having discussions within the organization about what to do with uncompensated care. How much of a discount we need to provide, how do we manage charity care? Do we need to change our policies? We fully expect that people are not going to be able to afford the exchange, that they're not going to have insurance anymore, but they're obviously still going to need coverage as they come through the emergency room. So I'll pause there. What questions do you have?
Go ahead.
Did I read that right? It was Medicare Advantage, that was the system that they were managing in Mountain West?
I'll get that next.
Okay,
That's
because I thought that we didn't,
that's-
wasn't great for hospitals, so we'll let you get to that.
That's different.
It was different, okay, so I got that wrong. Do you think that my internal sensor went off when you said that they're getting out of the market? What is? I mean, have you heard that maybe they're stepping back because we might see like insurance across state borders on the horizon?
No.
Okay, because that could be great for us.
Yeah, no, I don't think that's going to happen.
All right,
Yeah.
too bad.
Obviously, it's been a conversation for a long time, but
Well,
Yeah.
like if they're seeing it before I'm seeing it, that would be awesome, but.
My only, and this is more of an observation, I guess, your 3.6 or 1,500 people. I'm guessing, I mean, when you look at the economic study that's done here annually, average household income is what, about 80 grand, I think they predict. I think there's more on affordable health care than we're thinking by just taking that extrapolation. I think it's gonna hit us more than we're thinking is all. And I'm sure you're already thinking that way too, but I mean, the big beautiful bill is not as big and beautiful as it might be, but will it, the dollars that are going to the states under one of your other columns,
we'll get to that.
okay, I mean, will it offset, can it offset any of that? Is that for capital improvements?
No, that's totally different, separate purpose.
That's what I assumed.
Yeah.
Okay. So anyway, I think it's gonna impact us a lot more than just
I needed,
that small amount.
you know, I needed just a simple way to put numbers and have a rational basis for those numbers. I'm sure that everybody has a gut feeling about if it's gonna be more than 1,500, less than 1,500. That's how I arrived at my number.
We have about 18,000 in our district area, I think population, just as an estimate, 15 to 18, so. Yeah, I think it'll be little higher than 50, well, that's 10%,
So,
1,500, I don't know.
so, you know,
Anyway,
if this population chooses to pay the extra 20 to 30%, again, more pressure on households. And my concern is that we're getting to the point where this is going to turn into a significant cost issue for the entire country. There has to be payment reform. There has to be something that changes, because what normally happens is that once you take from Medicare and Medicaid and the uninsured, providers go to the commercial insurance companies to make it up.
Mhm.
They then pass it on to the employers, which then pass it on to the employees. And so the economics of all of this is that the young, employed, healthy populations are still footing the bill for all of the insurance in the country. So that's the exchange population. I want the board to be aware of it. We're trying to prepare for this. We're trying to understand how, as an organization, we're going to manage the uncompensated care. You know, what if we have to look at a dip in revenue, you know, normally we might have to consider expense reduction to some degree. And where does that come from? So these are all hard questions to ask and answer as we consider reimbursement.
The in-office hospital plan, we kind of dabbled with bringing that back out of the woodwork in the past, like Clint, you were doing that? The hospital, like the insurance plan the hospital offers, the in-house plan,
Member care.
member care, is that taking off at all? Is it like such a hard lift while we're dealing with other things? That's kind of how it feels like to me. Could be the answer, could be something we can really look into.
Yeah, I think what we have to be careful of is the hospital can't be the insurance company for all of this. I mean, we in a way become the insurance company because we pay for it. We provide the services without any compensation.
That's
And
not insurance, that's welfare.
what's that?
it's charity care.
Charity care.
Yeah, well, it's not charity care because these people probably don't qualify for our charity care policy.
So it's either write-offs or charity care though, right?
Yeah, well, and that's what I'm saying is I want to distinguish, you know, charity care are those folks that really just are, you know, they don't have any assets, they have very little income, they don't qualify for Medicaid, but they just need something to help them, and we do provide charity care in several cases. Then there are people that can afford insurance that choose not to get insurance. And they say, well, they have to see me in the emergency room by law through EMTALA. So I'll go and use the emergency room as my primary care office. And so what we're forced to do is say, well, okay, do we try to get them to sign up for member care? Member care covers primary care visits, and with some additional money, some x-rays and diagnostics and lab. And I think that we could offer that, but we don't want that to replace their responsibility to get insurance. Does that make sense?
Yeah, makes sense. If I'm running it as a business without potentially counting on government help, it makes sense to me to provide it if I can do it efficiently. Taking a premium in advance to offset when somebody comes in the door and we're offering it as a write-off. I just know, like, my family's always been self-employed and always looking for options that make the most sense, and we were out of the house before with like mandated coverage. this is a bigger conversation that we need to have right now, and it's not really on the table to discuss, but we'll just see what happens in January, I guess.
So member care is limited to employers.
Right now, it's
That would
limited.
be easier, like you get an employer to write the check.
Yeah,
That's what they think.
right now, it's
To a market.
to small businesses that they can offer as a benefit to their
And
employees.
it could be just one or two people in the small business, I don't know. But it's not to
That's how you're.
individual families if they're
Yeah, we're not managing
employers.
families. Yeah.
So I think there's gonna need to be more discussions about this, especially as it gets, our facility and the region. Because these are, again, 41,000 people are on the exchange. I don't know of how many of that 41,000 people are going to say, I'm gonna keep my insurance by paying 30% more in premium and deductible. So, all right, now to your point, the next thing that we have to keep our eye on is Medicare Advantage. There's lots of folks that are age 65 and older that have been approached by brokers to have a replacement to traditional Medicare by getting the benefits of Medicare Advantage, which is managed through commercial insurance. The only managed care offering that we've contracted with is United Healthcare. United Healthcare throughout the country in a lot of different counties is losing billions of dollars, mostly because of Medicare Advantage. And so they have opted to leave our market come January 1 of 2026. That means that people that have Medicare Advantage products, whether they were sold, in Utah, somewhere else, here, we don't have a contract with any insurance company for a Medicare Advantage plan, but for United Healthcare. That'll become null and void at the beginning of the year. Blue Cross Blue Shield of Wyoming has approached us. They would like to provide the state a Medicare Advantage plan. Most hospitals have dropped Medicare Advantage because, as I've told the board, the sarcastic remark is we refer to it as Medicare Disadvantage. Very difficult to get prior auth, highly regulated when it comes to discharge and number of days in the hospital. Very difficult to collect reimbursement from these plans. They want to hold on to the cash. The way it works with insurance companies is the federal government gives them a fixed amount per member that's on a Medicare Advantage plan. And that fixed amount is, so the insurance companies looks at that dollar amount and says, all right, we now have to manage expenses so that we can make a margin off of that. And what's happened over the last couple of years is there's been tremendous overutilization of those plans. So they've been using healthcare services more than what the fixed amount has been provided to these insurance companies by the federal government. So they're at risk for managing these patients. That's why they're putting in all these stipulations of prior auths, holding on to the money, making sure that it's difficult. And so we, as providers, we have felt like it's really not a good financial move to sign up for Medicare Advantage plans. And I know that a lot of people have signed up for them. There's people in our valley that push them. So we have to decide as an organization, what are we going to do? What makes financial sense if we sign up with Blue Cross Blue Shield of Wyoming? They know of our concerns. And I think that they're coming to the table with trying to address those concerns. So we're going to sit down with them. We're going to hear what they have to say. But I wanted you to be aware that Medicare Advantage plans in our area there's not going to be providers that have contracts with these plans.
So you're thinking a lot of people are taking Medicare Advantage. I mean, one of the first things I heard, and probably one of the only ones on Medicare here, is that don't sign up for Medicare Advantage. And I rarely hear things from the outside on these things, but that was one of the first ones. So I took that.
Rumor had it, if you switched to Medicare Advantage, then it negated, like if you went into the regular insurance, it pre-existing condition evaporates. So I think that you go to Medicare Advantage because you perceive value, you get care for a better premium, but like you have a hard time getting into the regular exchange. Is that true? We heard a little bit about this in Texas, but everybody agreed it was a really crappy program to try to manage, so.
Yeah, it's, I think it's because of those financial pressures that the insurance companies have, they have made it difficult, especially on providers, to see these patients. The patients, for the most part, I think are oblivious to the economics of it. They just.
What's it gonna cost me monthly?
Yep, and how much coverage do I get with, pharmacy, doctor visits, hospital, they just want to see their provider. And what we're saying is these managed Medicare plans are just too arduous and draconian with how they're paying us or allowing us to see patients and do the right thing for them, that we're saying not good medicine. And that's the pushback that's happening in the country.
So do we have any idea, statistical data that tells us how many Medicare Advantage would be?
I don't have those
in the
numbers.
county or anything, or?
I think we can get from United Healthcare how many lives they have in our county. And I think it's around 500.
But did they have to seek care elsewhere because their providers aren't contracted?
They will.
I mean, currently, they come in here.
No.
They don't come in here?
Because we're signed up with United Healthcare Medicare Advantage.
Oh, we are, yeah.
But come the first of the year, they won't.
They won't. January 1. They're not selling them in our, we're gonna sell them, I believe, in 3 counties in Wyoming.
That's it.
Lincoln's not one.
There was a map when we were in Texas that went through that, and you went in was much higher than what it is. And I think it's because we decided that because it's something we got ordered, right?
Yep.
Yeah. Did you verbalize what you picture? Like, we don't want to make guesses. We just see what comes January, or is there anything we can do?
Well, I think the wise thing to do is have the conversations with Blue Cross Blue Shield of Wyoming. I think a lot of people are hoping that we sign up with them. I think people do want a Medicare Advantage option. But at the end of the day, if it's going to disadvantage our providers, disadvantage the hospital from a clinical standpoint as well as a financial standpoint, we're not going to do it.
So can Blue Cross and Blue Shield tailor it for themselves? I mean, are they under certain guidelines because of the product?
They need a network of providers, right? If they're going to, they have to demonstrate to the federal government that they have sufficient number of providers to deliver high quality care at a low cost. And
But can they adjust, like, and make it easier to get pre-authorization?
they could. And so
They have those rules, they can probably change what the other company didn't choose to change.
yeah, so
It may make it a better plan.
you're absolutely correct, Arlo, is we would make sure that all of those elements are in the contract.
Okay, so those are negotiable.
Yep. Big beautiful bill.
You deal with it.
I think that the board, this is potentially a silver lining here, folks, is when you look at the rural health transformation program within the bill, essentially it's $50 billion, $25 billion going to the director of CMS to decide discretionary, his or her discretion, 50 or 25 billion that is divided up equally amongst the 50 states. Wyoming, with its low population, would be one of the highest beneficiaries per capita of this bill. So that is 500 million over 5 years, or 100 million to the state of Wyoming per year for 5 years. The state, through the governor, have to apply to the federal government for these dollars, and you only have one shot at doing it. So you can't screw it up with your application. We're still waiting for guidance from the federal government on the details of that application. As soon as, now it has to be, this has to go into play, I think, by the end of this year, this calendar year. So it's gonna go quickly. We expect some guidance by the middle of next month. The application may be being opened into October, November, and then the funds distributed. So part one to this is, are there legislators or are there people in the state of Wyoming that are going to say to the governor and the state, which I don't think that he's going to pay any attention to it, don't take those federal dollars. That's a possibility.
The governor's responsible to make the first application
Yep.
to the feds?
Yep.
Is there an agency in Wyoming that would be doing that application?
Yeah, I think it's the Department of Health. Yeah. So now Senator Barrasso is the main driver. He is on a national level the main driver for the champion of rural health. I think he expects and wants credit for this part of the bill. And I think we want to give it to him, but we certainly have to see if it's going to materialize. Part two to this is, if the money does come to the state, then the concern I have is, all right, what are the strings attached that the state is going to put in place to get access to it? And how is that going to be divvied out? So I don't want to get people's hopes up, of what could potentially happen. But there are, I listed out in my report of criteria that we know of that they're going to be looking for in the application, and I think in the disbursement of funds. A lot of these initiatives we're already tackling, and we have made significant investments on our own to expand rural health care and to give more access to people. So it's something to keep your eye on, be aware of. We do need to engage. We do need to make sure that we are heavily involved, and that's what we're going to do as we look at these next several months before the end of the year. Any questions on this?
You don't think the state would actually divide it evenly amongst all the counties or the hospitals?
I don't know.
Why would they do that?
And it's not just, if you look at rural health, it's not just hospitals. You got FQHCs, you got rural healthcare clinics, you've got, once the government puts out money, there are so many hands that want to grab it.
Yeah.
And I don't know how they're going to regulate it, and I don't know how it's going to end up. But without question, if rural hospitals in the state of Wyoming don't get financial help, there's a lot that are in trouble.
Clint, you had a question?
I'll hold mine till the end of his report. It's
Okay.
just backing up a little bit, so I'll hold it.
Okay. Next one, I just want to highlight, just make sure that the board knows that we're having ongoing discussions with our radiology group called MIA, not a great acronym for a radiology group. It stands for Medical Imaging Associates. What do you?
That's how I get read it over.
Sorry. So anyhow, they are looking at, they currently provide interventional radiology services at St. John's. And we are having discussions with our medical staff at providing similar services starting that up here at Star Valley Health. Just want you to be aware, on top of telerheumatology, interventional radiology, these are all these services that we think that we can keep care close to home without any more significant investment. We've already made the investment into the cath lab. When they see that cath lab, I think that they're going to, the interventional radiologist is going to say, hey, you don't need to come, if they reside in Teton County, you don't need to travel all the way to Idaho Falls for a procedure. I can do that right there in the cath lab in Alpine. So I think there is a way to capture the volume at various parts of the state by having these services available. Okay.
Do we have any concerns with our Alpine location for these types of procedures? Or I assume there's protocols and everything that have to be followed with medical staff. Are we within all the guidelines, I assume, that would need to be met so that we can, we're not at risk?
Yeah.
Down in Alpine?
Yeah, with any new service, any new specialty, we have to go through the credentialing process of these providers. We have to, they're going to do a site visit, and they're going to assess three things: equipment, staff, and supplies. And we do believe that where most of the immediate growth is going to be is oncology services. So we're putting the interventional radiologies in touch with various specialties on our medical staff and assessing what we can start with and how we can grow that service line. So we truly believe we've got all the equipment, we've got all the staff, we've got all the supplies, and as long as they're appropriately credentialed, I think that risk is significantly managed.
So my lack of understanding, like interventional radiology, I have a friend that's one. I thought that they like stent aneurysms or stuff, but the way you're talking is maybe like placing a fork or cancer treatments, or are you saying there's many different jobs in it? Or am I shut my mouth?
No.
What are we doing?
No, docs, help me out here. How would you describe interventional radiology as a whole, as it touches multiple specialties?
So interventional radiology is a specialty that has really evolved, particularly over the last 15 years, and continues to evolve as quickly as almost any specialty. So where they are particularly useful from an oncology standpoint is from biopsy standpoint. We use them from general surgery standpoint and others for drain placements, tricky drain placements in the abdomen. Their approach is much less, it's invasive, but it's much less invasive than for us to go in and place that drain. From a trauma standpoint, which will not play a part into this, they're able to save some organs due to being able to go in and shut the blood loss or the hemorrhage off from an intraluminal standpoint. They do ports and things like that, but we do that, so there's not necessarily a need for that at all. And depending on the individual, there's some other advanced trainings that may or may not play a part in this. Now, from a medical staff standpoint, we are very concerned with patient selection, obviously, because we've got a very nice facility there, but it's not near definitive care if there were to be a problem. And that's been always the problem, or the concern, and we have to be careful with from Dr. Gonzalez standpoint or whoever is there. It's not near an OR or more resources, and so patient selection will be critical. I spent some time on the phone with one of the interventional radiologists this week, and he's already doing some stuff in Jackson. He's never seen, Jackson doesn't have anything, so compared to what we have in Alpine. And it'd be shocking if he didn't use that almost for some of those patients, rather than having to drive all the way to Idaho Falls. I don't know, but he will. But they provide a lot from a from biopsy, from drain placements, from, some, you name it, from an introluminal standpoint, from vascular standpoint, they can do a lot of different things. Yeah.
So they could be credentialed to do quite a few procedures, but then we would look at and say, what do we think we can offer safely here? And then
Correct.
we, anybody that's emergent, that's a totally different facility, and
It is.
anything that you think, oh, our guy's coming in, and then you schedule him one Friday a month or something.
Yeah, it's interesting. So I asked him, they've been doing Jackson for 5 months, and I don't know if it's apples and apples, but he's had a full day every time, whatever that means.
Yeah.
And so I would anticipate something similar. The thing is just educating the medical staff and making sure they're aware. And again, from an oncology standpoint, that's really probably the first line that we would attack this.
Thank you.
I failed to mention in my report that we are getting close. No, we have signed the agreement for telehospitalist nocturnal.
Cool.
So I want you to be aware that during the evenings, we will have access to, now this is gonna still take 3 or 4 months to implement, credentialing and the like. I don't want to tell you that's happening right now, but in 3 or 4 months, our hospitalists will have, the ED physicians during the nighttime will be able to consult with a hospitalist at Intermountain on a patient, and if we need to admit that patient during the nighttime, it gives reprieve to our existing hospitalists so that it, one,
Quality of life.
Yep, quality of life. 2, helps with recruiting and the package of recruiting of what things can be like if you were to come here and be a hospitalist. And 3, I think it really helps our emergency room physicians with having an avenue of how to manage the patients and being able to hand off those patients in an appropriate way. So a good step forward. We negotiated a very, very affordable price with Intermountain. I think they're gonna see our volumes go up, and so they'll probably come back to the table and ask us for more money, but it's about $45,000 to have that service available to us.
A month, a year?
Year. Okay. And then lastly, want the board to know that we had a very successful first meeting with all of the stakeholders around EMS. We had every single mayor there, all the administrators there, county commissioner there, and we were able to have a good discussion about the state of the union when it comes to EMS and talk about, where do we go from here to make it sustainable? We're going to be very transparent. We're going to provide all of our financial information to these stakeholders, and we're going to seek to explore a model that could potentially work in our area. I think at the end of the day, folks, I think we're going to most likely have to turn to the taxpayers. If they want EMS and they want a sustainable model, we're probably going to have to do a public campaign educating people on EMS and saying, are you willing to pay for it going forward? So nobody wants to go there. I just don't see another avenue but for having those conversations. So first one, it's been kicked off. We'll have another one once we provide them some information and get it on the books, but just wanted you to know that we've engaged, everybody that's probably going to be impacted by this, and we'll see where it goes. Any questions?
Was there an overall sense of willingness to, let's figure this out, or was there more of a good luck?
Great question.
Attitude.
Clint. I think deep down inside, Probably a very small minority would like to go to back to the good old days and have volunteers.
It's not gonna happen.
And so there's that sentiment. There's that sentiment of saying, hey, let's just see if we can raise the banner, the rallying cry, and make this such an attractive thing to do that all the go-getters out there will sign up and carry us forward with this. That's obviously the least expensive way of doing it. The reality is from the majority of the group is that's not going to happen. And the mayors feel as though they can get behind something and they can carry the political water, but they're going to need probably the hospital's financial coffers to do a public campaign. They can't pay for it. They're going to need somebody else to pay for it. So the other concern that they had is, all right, Dan, well, what happens next November if we don't have a solution? And I said, well, the hospital, and if I spoke out of turn, board members, you let me know, but I said, I feel very comfortable that our board and the hospital, we want to be part of the solution in this going forward. We want this to be successful for the community. We're not going to just drop this. If we need to extend a contract, if we need to talk about how we continue to move this forward and support EMS, we're going to do that. However, the condition, I said, is we've got to see that there is substantive progress in a direction that we think is going to be viable going forward. Okay.
Good question. You said the first meeting, and then it sounds like there's a follow-up. Is there any intention of doing something on a regular basis?
Yes.
Okay.
Yeah. So we also asked the question, who's not here that needs to be here? And there are a couple of other political figures that we want to bring in, state representatives, so that at the state level they understand what we're trying to do this part of the county.
What about fire chiefs? Were they there at this meeting?
I asked, again, who the mayors would like to have there, and I brought up fire chiefs, didn't I? Maybe I didn't. I can't remember.
I thought you did, but
They said, let's keep it to those two individuals, those state representatives for now. I think that in the future, we did have one fire chief there from Alpine.
He's one I'm glad that was there because that seems like a no-brainer. As expensive it is to house in Alpine, I know you guys are considering moving that to Etna, but like we did have an agreement where we were sharing that space. And when we're talking about these resources coming together, I do love the idea. I don't know why there's this discord. There's so much going on that seems like a huge mistake.
Yeah. Well, I think there might be opportunities to save. I think that
by working together,
Yeah,
collaboratively,
by
with
working
all of these emergency services,
without question,
and we
and
take them for granted, I know that.
Yeah.
But when everybody's feeling the pinch, if we can be more collaborative.
without question, and really that's the goal, is to create a spirit of collaboration. And I think we got that.
Good.
So let's see where it goes, and I'm sure that there's going to be some bumps in the road. There's going to be, but we got the right people in the room, and the conversation is happening.
This is in the newspaper that I was looking at adding on to their fire station. Maybe I was way too asleep.
You read the paper, you reference something in the paper, I'm like, eh?
But I swear there was a lot of things that I'll be looking at an expansion project on there with Firehouse. Maybe I'm crazy, but I thought I heard that. I'm just, if they're looking at an expansion, and we're looking for new places to be, and maybe, like you said, come back together with that EMS and that fire might be, especially when I was at that meeting.
Yeah. I'll inquire.
I didn't see that in the paper. I read it and I didn't see that. I think that's the one I may have made it up. It's about 3:30. I haven't been to any town council meetings, but I did in Alpine, but I have not heard that. That certainly could be. They just filled, I mean, the space we were using for a while, I think got filled with their new ladder truck, which is why we were parked outside, last spring, I think, for a while. So, maybe they are because they filled up. Be an easy question to answer by getting hold of Chief Mike Boyd.
Can I ask publicly, because you had this meeting with them referencing the contract, it expires November of 2026. Was there discussion, I feel like Ms. Matthews, she brought something to our attention where we're using our supervisor in a certain way, and then this summer we thought that we're working towards the winter months. Is the plan to keep what you have going now, or are you gonna pare back?
Well, it's interesting that you say that. Now that this group is starting to think, all right, well, we might have a joint venture here, and what I don't want to do is add to the cost structure and hand it over to this joint venture, right? So we may have to have, as a group, they're going to see the dollars per hour that we're paying for, an EMT, a paramedic, and the various levels, the amount of overtime. We're going to be extraordinarily transparent with them. And then we're going to have to pose the question, all right, people are telling us that we're understaffed. Here's the call times. Let's pretend like this is a joint powers board and you have this business decision in front of you. Would you spend an additional $200,000 to cover, would you to add that staff, or do you want to hold off and do a wait and see? It's when you're the man in the arena, that's when the decisions, when your butt is in the sling, that's when you really have to think long and hard. When your butt's not in the sling, yeah, well, I could be a food critic till, I'm, until the day I die, and not have any repercussions. So what we want to do is really take that current sticking point, and we want to pose it to this group and say, okay, we can easily do this, guys, but come November, there's another $200,000 that you have to come up with.
But your verbiage to me makes it sound like you do see the contract as having the staff in place that we have. Do you know what I'm saying? I can reword that if I need to. I'm like not trying to cloak anything. I'm saying, Kenzie might have looked like the squeaky wheel. She brought things to my attention. I've been digging into this. I happen to live in Thane. I think it's a pretty central location. To have somebody that's kind of intended to be overlooking the seriousness of all of the things in the valley locked in there. Yeah, I mean, it looks like dollars on paper, but if it's anybody in this valley that's life's at risk because of that, then I'm like, what's $200,000? And I'm frugal, so, governments serve a purpose, and I know that there's no regulation for the EMS, but there are a lot of things that I can do without versus like just the general safety of people. Fire station, I voted for more taxes for myself for Mid-Valley Fire, like, that's very opposed to my nature, except I thought, you know what? We should all enjoy the benefits of fire protection, and I think people think everybody that has complaints about the hospital, I pay taxes for things. Sean just had a conversation, and when you tell him it doesn't even cover EMS, like it is where I'm very comfortable with tax money going. So I'm just putting that out there. I'm watching that. I think the contract does stipulate that we should have those things in play. If they want to make that change later, it's in a contract right now. And I think we have an obligation to fulfill that contract. And I think I'm so impressed with the contract. I'm so impressed with the EMT. I don't really want it to change, and I want it to be affordable. But I'm glad the conversations are happening, and I'm like not trying to bash the man in the arena. I get that, but it's important. I know you know it's important.
We do. We want to be, right now it's not, the cost isn't borne by the government.
I understand that.
Well, I guess in a way,
Not
partially
really.
it is through the hospital tax levy, which we have chosen to, which we made the decision to do that. But, the reality is that, if you were to compare our staffing levels for this valley for 18,000 people against other counties in the state, they would say, what are you complaining about?
Yeah.
I mean, that's the reality, guys, is what, you know, how good do you want it, but how do you pay for it? And, you know, my point is that here we're trying to be good citizens, we're trying to help, we're trying to solve the problem. And I don't think that everybody completely understands the economics of an additional 200,000 and the pressures that it puts on other parts of the healthcare system.
The entire year's net earnings is less than 200,000, so.
Yeah, so.
You could go from
But
profitable to non-profitable.
It's your opinion that it should be like these advanced level EMTs, but my opinion is that it should be one of those paired with, like, some guy that wants to be that guy one day. Nurse, CNA, like, it's an opinion. You say $200,000. If it was my business, that's not the number I'd be looking at. That's an opinion. And you're like that, but this isn't really what this is meant for. I just wanted to say, we have a contract. Feeling a contract is one thing. I think that contract does lead to safer population, safer health for the entire population. And I'm all about equity.
Yeah. Well, this is the debate, guys.
It's the debate. You don't want me in that meeting, but I'm really glad that you're having those meetings.
But I think you can say that we are fulfilling our side of the contract.
When we tried to reconfigure to save money, I don't think we are. That's my opinion. If somebody died and they took it to the court of law, I think we would lose the
What I'm saying
case.
is, we as a group, as a board, we're not going to violate a contract. And you may have an opinion about what it says, and somebody else may have an opinion about what it says differently. And we will follow the advice of our legal counsel that we are in compliance. We're not planning to break any contracts, in my mind. And we have, we have that one.
Yeah.
And so, there may be interpretations of what that contract says, and you can have your own opinion, and I can have mine, and we'll probably have 10 different opinions. But we're gonna fulfill the contract that we have. And we've said that. I think, haven't we? Yeah, so.
Right now.
And that is that's the way we're handling it. Dan, I think, is very foresighted in moving forward and finding out and getting this group together.
Mhm.
And they're the ones that have standing in that contract, and we're gonna have to renew it or something.
Mhm.
And so I think it's a great time to get ahead of the game and figure out what the community wants and what they're willing to pay for. Because, I mean, those decisions are gonna come down and we may not like them.
Understood.
It's a decision that every volunteer fire department has. How much are we gonna put into it? Can we get, I mean, everybody has the same decisions that I think Dan is talking about with this joint group. So, and I think those will be ongoing. Cole?
I just, I guess my thoughts are is that our duty, regardless of what's to come in November and the cost and everything that we're talking about right now, that's going to have to get hashed out. But I think that our duty right now revolves more around the contract and fulfilling our responsibility of the contract to be signed.
Mhm.
And then we'll hash out, stuff that as we get more information along the way, all stakeholders get all the information they need. I think that's something that's to come. And so I guess my point being, I think that, our duty right now is to, it revolves around the contract, and the rest of it, we'll get more details down the road, right?
Yeah, I think we will. And I think to your point, Abby, it isn't an essential service. And so it's not pointed to any one group.
Yeah.
So the groups that are affected have to get together, and that's what they did in the original. I mean, I wasn't here, but I remember coming here and there was volunteer groups in 3 different cities. And there probably at some point in time in our past in Star Valley, there were 0 ambulances. And the group got together and said, we need to solve this. And they started solving it, and it evolved, and then it got not as good as they'd hoped because of this volunteerism. And it's not us, it's the nation. This is happening to states, rural EMS, fire, everything all across the nation. So we are now, again, getting the groups together that are affected to say, how do we handle this? And I think it's
A lot of change.
definitely the way we want to go.
So have our legal team have they reviewed the contract, and are we meeting that contract? I know there's
Yes.
disagreement there.
Can I pump the brakes? I really don't want to have a discussion about compliance of a contract unless we're in executive session.
That's going to be a litigation discussion, I think, or legal discussion, right? Yeah. And so if you want to bring those items up, I think we need to do it at the appropriate time. But in general, I think we can safely say we will abide by, we fulfill all our contracts as a hospital. I don't know one that we haven't. And so we will continue to, that's our plan. And I think we can safely say that. And so but everybody's got a different opinion. When you come to contracts, that's why we have attorneys. Everybody has a different opinion, at least from my viewpoint. So I think we need to move on. And unless you have other discussions about the meeting that Dan had, I don't know that we can get into the legalities of everything at this part of our meeting. So any other questions for Dan on his report? I think you were done. Is that right, Dan?
Yeah, there might be, I didn't cover everything just for the sake of time, but those are just the highlights.
Any questions for Dan? I guess I need to get back up here. Okay.
Thank you, Mr. Chair.
We have an FYI. I think you've seen either a text or an email about, and some have already answered, I think, right, Andrew, for the December 2nd holiday breakfast, 6 to 9 a.m. Don't come at p.m., you'll miss it.
Just, Mr. Chair, may I put a plug in?
Please.
I think the organization loves to see the board members. If you can, if you want to serve some pancakes and you want to throw a couple of pieces of bacon on a plate, say hi to the employees, I think it will make just a huge, just nice little, it's Christmas time, guys. I mean, it's the time to spread good cheer. And so if you can make it, great. If you can't, we understand, but we always want to put out there opportunities for the board to engage with employees.
Sure. So anybody feel, those that haven't answered, there's the pitch. If you want to be involved, that'd be great.
Mr. Chair,
Mike, yes.
I know this is highly irregular and I'm not on the agenda, but I wonder if the board would indulge me in giving you some fresh information that not even any of the admin team know about. That's a very positive.
Oh, heavens, that sounds really intriguing.
Okay, all right. Thank you very much. I won't take much of your time, but there's a couple of things I'd like the board to know. I've had the opportunity to work with our revenue cycle team the last several months. And they're working their guts out. I just want you to know that. And it's not just the billers or the coders. It's Dr. Callan. It's Corey Ricks, our clinics director. It's all of their teams. And it's all of our physicians trying to get your charts closed. Just a couple of really positive things for you to do. We received a payment on a claim today that was 2 years and 1 month old. It took that long to get the claim resolved. And we've been working our guts out with Blue Cross and Blue Shield to get these old claims resolved, and we're making great progress. I wanted you to also know that we have, since July 1st, we have not been paid for professional fees from Medicare since July 1st. They've denied all those claims. today, just a few minutes ago, I got a note from Sarah Merritt that she's been working with, and this is much thanks to Senator Barrasso's office, because we asked them to give us some help with this. Where there's $1.3 million in claims that Medicare's denied, and we got it resolved today. And those are processed now, and we should be paid next week for that 1.3 million in claims. And so this is, I just want the board to know that we're really working hard to improve and optimize our billing and collection process. Again, the consultant we have has asked us to, if we can get down to 55 days in AR, that's doing really great. If we can get down below 6 in our, in the days that it takes to prepare and drop a claim to the insurance companies.
Candidate for billing.
We can get below 6 days on that. We're really close in that area. We're pushing to get to 59 days in accounts receivable at the end of this month, just, by the end of the day tomorrow, hopefully. So we're working really hard and making improvements. I think one of the most awesome things is that we're working together as a team with a common purpose. And I think that everybody should be complimented for that. I wanted you to be aware of it because it's been a team effort, and everybody should be recognized for that. So I just want, another positive thing, and Cole will like this. We have a goal to bring cash in the door every week of $2.5 million. That's our goal, $2.5 million to bring in the door every week. That's $500,000 a day. Last week, we exceeded that goal by $300,000. That's the first time we have hit that goal, and we exceeded it by $300,000. So just I want the board to know how much progress we're making in our revenue cycle process, and I think it's been a great opportunity for us to improve how we do business. Just thank you for letting me share that.
Thank you, Mike.
Yep, thanks, Mike. Anything else that I've missed? And we're gonna take a 5-minute break. We need a motion to go into executive session. And those that forgot it, I have the motion, if you don't already have.
On board.
I make a motion to go into executive session for the purpose of legal matters, real estate, and personnel issues. That's what it says.
And litigation.
And litigation, and/or litigation.
That's pretty close. Is that close enough? It's been moved. We go into executive session for those items. Second by Mindy. Any further discussion? If not, all those in favor?
Aye.
Any opposed? We'll now take a 5-minute break. Try to be back at 20 after.
Sheila says yes. Governor will apply for it.
Hey. Good, how are you? Well, good. You deserve to be.
I don't know about that.
Okay, we're on. We're back into open session. We need I need a motion on executive session minutes for July 22nd.
So moved.
Motion by Abby,
I'll second.
Jeff is seconding. Any discussion on those executive minutes? Any amendments? All those in favor?
Aye.
Aye. Any opposed? That's all I see on the agenda. Do we have another motion?
I'll move to adjourn this meeting at
Abby
7:44.
moves to adjourn, dies for lack of a second? No.
I give a very reluctant second.
You can stay then.
Lynn seconds that motion. Any discussion? All in favor?
Aye.
Thank you,
Any
everyone.
opposed?
You don't agree with my. Well, I guess technically, you're gonna answer the question that I pose. And if I ask the wrong